Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speaker's presentation, we will open the floor for questions. Instructions will be given at that time on the procedure to follow if you would like to ask a question. It is now my pleasure to turn this conference over to Chris Hund. You may begin.
Thank you, Chantel, and welcome everybody to Using Simulation to Enhance TeamSTEPPS Implementation. This is the July webinar in our monthly series of TeamSTEPPS webinars for the national implementation. So thank you all for coming. I hope you all had a nice 4th of July. I'd like to start by thanking the project sponsors for the national implementation of TeamSTEPPS, those being the Agency for Healthcare Research and Quality, specifically Dr. Jim Battles, who is the person who directs and leads all of this work from AHRQ, as well as Heidi King from the Department of Defense and TRICARE. TeamSTEPPS has always benefited from the work and the dedication from both the Department of Defense and AHRQ, so I'd like to thank them both for all of their support. The project team for all of this, this is a contract from AHRQ that is held by my organization, the Health Research and Educational Trust. We are the nonprofit research and education wing of the American Hospital Association. My name is Chris Hund, and I manage the project for HRET, and the project director is Barb Edson. I'd also like to acknowledge our partners in this, Impact International, especially Dr. David Baker, who has been working on TeamSTEPPS from its inception and is the team lead with Impact. So just a couple backgrounds that I always give in these webinars. TeamSTEPPS pretty much revolves around a master training course, a 2-day training course, which is something where people come in and it's a train-the-trainer approach with the hopes that you go back and spread the good word about TeamSTEPPS in your hospital or organization. It really prepares you to not only think about TeamSTEPPS from the level of what the tools are, but also how to go back, implement it, understand how it might work in different parts and different environments. My project, the work here at HRET, we support a couple of helpline options if you ever have any questions about content or about any sort of administrative type things, about getting into trainings or anything else. So right there is our email address and our helpline phone number. You can also find these by going to teamsteppsportal.org. Okay, just a few rules about today. The way we like to do this, especially when there's a large number of people on the line, is you'll see on the left-hand side of your screen a discussion area. If you have any questions throughout, if they're questions for Dr. Korndorffer or if they're questions about anything logistical, drop them into the discussion area. We'll answer the logistical questions as they happen, and any of the content type questions we'll queue up for the end and kind of organize them so that we could ask Dr. Korndorffer questions in a logical order. And then once we exhaust all of the questions from the discussion area that have come in over time, we'll then open the floor for questions at the very, very end. Okay, I want to now introduce today's presenter, who is Dr. James Korndorffer. He is the medical director at the Tulane Center for Advanced Medical Simulation in New Orleans, Louisiana. He's also directs and has a lot of different appointments, as you can see, as with the general surgery residency, as the assistant dean for graduate medical education, as the professor and vice chair for the Department of Surgery. But what is also where I know him best and where I interface with him, of course, is that he's been a TeamSTEPPS master trainer for the past 3 years, and that he also directs the work of the Tulane Regional Training Center, which is part of the overall TeamSTEPPS national implementation. So more than 3 or 4 times a year, they have trainings down in New Orleans, and it's a very, very interesting experience where folks get to practice their TeamSTEPPS skills in their simulation center. I highly recommend it. It's a lot of fun to go down there and do a training at the Tulane Center. So you'll hear a little bit about today what they're doing, what they're up to, and how they use simulation to teach TeamSTEPPS in their system. So without any further ado, Dr. Korndorffer, I'd like to turn it over to you.
Great. Thank you, Chris. Also appreciate the props for the simulation center down here as well. And hopefully what I'll do today is go through a little bit about really kind of what we do with simulation down here. I want to touch on the idea of how we use the simulation strategies, particularly to teach TeamSTEPPS. Also try and get into some of the scenarios that we use and what we feel are appropriate and how to pick those scenarios, because they may not fit necessarily each of your other institutions. And then finally, also utilize the simulation to find out if it works when you go back to your own home institutions. So this is probably one of the best definitions that I've really seen with simulation that Bill McGahee has had out really for about 15 years now. And simply stating that in a broad term, simulation really is a person, device, or condition that attempts to present education and evaluation problems authentically. And I really want to focus here on the idea that it's education as well as the evaluation side of things. Now, I will say this, it does bother me somewhat that I'm giving a lecture about simulation, because as you're going to see through the rest of the talk, that I do feel that simulation really is a vital aspect of the not only the learning process, but also the assessment side as well. When most people think about simulation, they think about this. They think about the airline simulator. And they wonder, well, you know, with medicine, we don't have this yet. Well, as a background, just briefly, people understand that this is actually one of the first simulators for airlines. This was built in the 1930s. It's called the Link Trainer. And essentially what it is, it looks probably no better than those little quarter things you put in outside of Walmart or Target, which you put your kid on and it moves around. It was actually run by fellows that they took from an organ. But in short, if you think about it, this is where they started in 1930. We're now at 2013. They've been doing this for over 80-something years. That's how they were able to get to this. We haven't been doing this for 80-something years at this point, but we've made a lot of strides over the last several years. So what I want you to think about when you think about simulation is it doesn't have to be this perfect event. Case in point, this is a simulator for a baby bottle. It works. And that's really the important aspect about simulation. You need to find something that actually works. When you think about simulation methods, something simple as an animal cadaver model is a simulator. Prosthetic models certainly exist. People talk about the task trainers and the video trainers. We're going to focus mostly on the use of a simulation center today to try and reproduce that healthcare environment. But you can actually take that into your own institution as well and do in situ simulations. And that's where you can really focus on whether the training actually is succeeding or not by putting them into that in situ situation. So we want to focus really on two things. Number one, using simulation for education, that is training, as well as using it for the assessment side. In other words, ensuring your successful implementation. So with education, it kind of can be broken down in a couple aspects. Why is simulation so important with education? Well, I think if you think about it, this is a very nice summary of a paper that came out, and you look at the ideas of what are the best educational practices. And if you look at it on the left, especially with adults, as well as children, quite frankly, active learning is much better than passive learning. Again, going back to the idea, I'm giving a talk on simulation. They talk about how the idea that in a 1-hour lecture, most people may remember one or two things during that entire lecture. But you let somebody utilize it and repeat it over and over again, That's realistic learning. That's how you've learned everything pretty much through your life if you think about it. Same way with just the language. Immersive language certainly works better because it is active learning. The next step is prompt feedback. The idea that whether you're doing something right or wrong, if you get that quick feedback, you can then make a corrective action. It's certainly much harder to correct somebody doing something wrong after they've ingrained that wrong behavior than it is if you can identify it first and correct it at the beginning. Additionally, with best educational practices, the high expectations. You set those expectations up front. The objectives are there as well. Quite frankly, even the outcomes are set ahead of time so people really do understand what to expect. Especially important if you think about it with the team approach and TeamSTEPPS is with the best educational practices, you have a collaboration among learners. You're not putting somebody in a cubbyhole somewhere and giving a book and saying, go learn them. That's not how we do things. So, in fact, you can work together, and especially in this situation as a multidisciplinary team or in crisis resource management and the skills that you have. Same way that you deal with multiple individuals, each person has a slightly different way of learning. And you can, with simulation, you can actually use those methods, those learning strategies. As you'll see, we go through a few of these that really can help those various diverse learning aspects. And then finally, you really do have a significant learner-faculty interaction. Again, it's no longer here's a book, go learn it, but in fact you really see the teacher as a coach or facilitator of the learning process, which is so important even within the TeamSTEPPS training itself. So, with this respect, let's look at a couple of these very specifically. The first one being active learning. When you think about simulation with active learning, the idea there is you do allow someone to go through that described as deliberate practice. And in this case, it would be deliberate practice of teamwork. You're given a defined goal. You certainly have the motivation to improve. You're given the feedback you need. And the feedback actually can come from multiple areas. Rarely does the feedback here really come from the instructors after we go through the simulation. More often than not, the feedback actually comes from the person or the team that goes through the simulation themselves. They evaluate what they did, and they're actually probably their harshest critics. Additionally, the individuals in the room itself give you an opportunity to have that feedback as well. And, of course, the simulator, depending on the situation, may give you feedback as well. And the great part of this is that you can go back and repeat it again and again so you can actually put those things you learn into practice. Another aspect that's so important with learning is the idea of the collaboration among those learner groups. And one thing I'd bring up is the idea that you really do have a safe environment. You're telling individuals, if you think about it through TeamSTEPPS, to utilize the cuss words, to express concern, or this is a safety issue. Whether we like it or not, and there shouldn't be, but whether we like it or not, there's certainly still a somewhat of a hierarchical concept within medicine in itself. And there are a lot of times people aren't really willing to speak up. And I would suggest to you that if you can get them comfortable speaking up in a simulated environment, then they will be more comfortable when the real event occurs. Likewise, if they're not even willing to speak up in a simulated environment, the chances of you having success in the real world is a challenge. On the flip side, the willingness for someone to listen to that person speaking up. And that's so critical as well. It really goes both ways. So you can actually help to develop those skills and abilities that they really need when they move forward in a very safe environment. I'll give you just one example that happened with one of our simulation trainings that we did here. One of them was dealing with a external pacemaker for placing it on an individual that had a bradycardic episode. Well, there was a relatively new ER nurse that was in the simulation with two doctors, two nurses, and they were going through the process. As it turns out, the device that we have here was slightly different than the one they used in their home institution. Well, they connected the external pacing device, and plain as day on the video, you could hear the new nurse say, well, shouldn't we turn it up to try and capture? Nobody said a word to her. What happened was, when we sat down and reviewed this, She was willing to speak up initially, but nobody responded to her. And since nobody responded, she thought she was wrong. She actually said nothing the entire rest of that simulation. As it turns out, when we got together, none of the other 3 people even heard her speak. And with that, she was doing the exact right thing, but yet it took them 3 to 5 minutes to get to that point, as opposed to something she would have said as well. It helped her realize that, no, I am willing to speak up because, in fact, I was right. So this was in a very safe environment, and hopefully that will make a difference long term for her. With simulation focusing on team training, really the idea there is it comes down to a lot of role-playing itself. If you think about it, this should be really traditional simulation for the team. It allows them to go through their normal practices, their normal processes, and you really do what comes naturally for you in that situation. But the key point with the simulation is the learning typically doesn't come from the actual event itself, but really does come from the debriefing itself, the debriefing of the team process that you have at the very end. So to accomplish this, what do? Well, first of all, you want to make sure you have the clear goals and objectives. With the simulation also, you need to also make sure you know what learners are involved. And this is actually a challenge when we have with the master training down here, and we actually get the list of individuals that are going to be here, to try to identify who the learners are and what their experience level is. If you have medical students or nursing students, or for that matter, if you have individuals that work in your food service industry, whatever it may be, as opposed to your physicians working in an emergency department or in surgery or OB, it really does make a difference. And you need to tailor those simulations to them to help give them the best event they can have at the time. You also certainly have to develop the plans of debriefing. How are you going to accomplish it? Do you have video available? Are you simply going to put a video camera in there and then have them go back through it? And then lastly, of course, how are you going to achieve those objectives that you have set forward? So putting it all together, really what it comes down to is you can certainly integrate procedural skills if you want to. They can be strictly the team aspect of doing those procedural skills. One of the things we've done here is the team approach to putting in central lines, which I'll talk about in just a minute, where we have nurses and our residents working together as a team putting in central lines. And you really do think about it, you're focusing on the real world. You have those, the hard skills in the sense of the procedural aspect simulation, but also the other competencies that are out there, the idea of the communication and the teamwork itself. And putting this all together, you really do wind up moving that together with the idea of that safety aspect, where everybody there is important in the care of that individual patient. I'm going to go through a couple examples of how we use simulation specifically here at Tulane. One of which we've done is our what we describe as our Rural Emergency Department team training course. We have several critical access hospitals where the emergency room is typically staffed by not ER-trained physicians, but physicians that are actually in their community that do cover their emergency department, as well as the nurses there as well. And what we do, we have the nurses, some of the pre-hospital individuals, some of the allied health professionals, as well as the physicians come down to the training course. Now, simulations themselves are broken down really by specialty itself. They give some procedural practice, which they would like, but really the focus is really on the teamwork process. We asked their CNOs and their CMOs what they wanted to look at, and they came up with what they described and we termed their high acuity, low frequency events. These are areas where you really do want to work well as a team, but you don't get a chance to very often. I liken this to the whole idea of sort of the Miracle on the Hudson. The point being is that whole process was a classic high acuity, low frequency event. Thank goodness it's low frequency, but it is a very high acuity event, and if you listen to their voice recorder, everything was very calm, as if it was just they were going through their regular checklist and working together as a process. So using that high acuity, low frequency aspect is really the areas we focused on. We then identified an agenda, sent it back to them, made sure they conferred with the plan, identified instructors for each of the specialties that we needed for that, and then the hospital sent teams between 6 and 8 individuals down. one of the key aspects of the hospital administration, as well as the instructors, and particularly the participants, when they come to a simulation center where we're running something like this, their thought process is we're going to go practice some advanced skills. And they think of their advanced skills of, what we'll go through is how to put in a central line, how to do a tracheostomy if necessary, those kind of things, whereas we really want to make sure they focus on the idea that what we really want to do is to focus on their teamwork, their individual communication skills, and their leadership skills itself, and not really focus specifically on those advanced skills as far as the procedural aspect. It's broken down as a 2-day course. We have combinations of physicians, particularly, and nurses. What we start with is all these individuals have now gone through, because Louisiana has actually sponsored a large number of these hospitals to come through team training, TeamSTEPPS training, and TeamSTEPPS master training. So we do a TeamSTEPPS refresher course on day 1. In a sense, this is really the TeamSTEPPS essentials, and it really refreshes their memory of the concepts of TeamSTEPPS. Then we break them down into smaller groups, and we do go through OB scenarios, neonatal scenarios, pediatric, again, airway, and then finally at the end we go through a rapid response with all of them there together. Problem with simulation, though, is that sometimes, it just doesn't work exactly like you have planned. Like a lecture, fine, I can have it planned out here. I know what slides are going to come next. But when you put somebody in a situation, you don't know that they're necessarily going to do exactly what you're expecting, even though you've run through it a couple times in your own center. Example here is if you have a scenario that starts dragging out because you have a physician that really is, last time they ever delivered a baby was in medical school. And unfortunately, they don't really recall what to do with respect to, say, shoulder dystocia. And unfortunately, perhaps neither does anybody else in the room at the time. Now, this is a procedural mistake, so how do you accomplish this? You can let them certainly continue on and on for a long period of time, but the other possibility is, since that's not your main focus, you can certainly interject for a very short period of time, get them over that hump, and then allow them to continue to the rest of the process. Additionally, after you complete things, you have individuals come back together, and the fact is, I've learned through this is that pretty much everybody in the healthcare industry, we're all pretty competitive individuals more often than not. And a lot of times what happens is people will come back into the debriefing and they'll start looking at things, oh, well, I didn't do this, or gosh, I took too long to figure out what the diagnosis was. Now, they're thinking too long, 2 or 3 minutes, those kind of things. But unfortunately what happens is that they really focus on these kind of abilities a lot of times. And let's face it, that's what we've thought of when we go through training throughout our careers. So that's really not the purpose if the purpose is team training. So the way to manage this, there are a couple options out there. Number one is you can allow them to focus on it for a minute or two. And you actually tell them up front, okay, we're going to look at the medical aspects of this for about 2 minutes. And let people talk about what they did right or wrong from a medical standpoint. And at that point in time, you really do need to just move on. Because at that point in time, you really get to what you're focusing on, and that is the team aspects. So, again, this is our rural training, and I'll show you really kind of how does it work. It's kind of interesting is that this actually was in their local paper, one of the places that we did the rural training. It happens to be a hospital that does not have OB available. And in fact, they typically have to transfer any OB or any patients in labor somewhere, if I'm not mistaken, 30 to 45 miles away. Part of their training, including working as a team, and we had multiple processes of actually delivering normal vaginal delivery, delivery for shoulder dystocia, breech delivery, the like. And so they all went through that as well. But what they specifically did is they all went through the process together as a group. And interestingly enough, this actually happened. A patient came in labor several days after they came down here. Now, it's fascinating to talk to them. This was an article they put in, but actually talk to them afterwards, is that everybody was calm, they were doing their job, and nobody thought anything about it. The idea was they were working together as a team, and realistically, the team itself worked significantly better than any one individual who might have come down and tried to practice their own skills on their own. When we do the master training down here, we do it a little differently in the sense that we do have several scenarios that we run through. And I'm just going to give you a couple of these scenarios and what we've learned from them as we go through this. Number one is we realize that when the master trainers go back to their home institutions, a lot of places have started rolling out the team training to everybody in the hospital. That may mean healthcare professionals, but it really may mean other individuals as well. For example, on the first scenario you see here, what we have quite simply is a hospital visitor that collapsed in the cafeteria. And as such, no medical history available, but the key point is that the first people on the scene may very well be your food service people, somebody else in the cafeteria, and the like. So we try to avoid the idea of the location necessarily being your classic rapid response, showing up in a hospital room where everything's immediately available. So these are things you can think about as well. Another one we've done is when the nurse comes back into the room, for example, after somebody's been to radiology, just for a simple chest x-ray, complains of chest pain, and he's the first individual to find the person. So, of course, the code team has to be called, and how do those people respond as well? Likewise, we've done things such as somebody coming from home, they can't walk because of pain in the hip, but, oh, by the way, when they're being moved from one place to the next, she's dropped from the stretcher. So there you can also work on the idea of how do people work as a team when they're picking the individual back up, even dealing with the individuals that are moving people around your hospital itself. The other one we actually like, and this actually works very well, is that we have typically we'll have people playing the role as nurses. And again, we try to identify individuals that were nurses that will be doing this in the ICU setting. And we actually put a Confederate into this scenario here at the SIM Center. Well, our Confederate goes in with the nurses here during doing team training. Now, understand, this is just after they've heard all of the things talking about being concerned, that it's a safety issue, that they need to speak up. Just after this, we have one of our residents go in, purposely contaminate themselves. We also have them purposely trying not to do the line very well. And it's amazing the number of times that people will not speak up. And this really does go back to the idea of this is in a very safe environment where they should be able to speak up, but oftentimes they still don't. Now, they look at this on the backside with the video, and sure enough, they identify what they've done and realize that, no, next time they do need to speak up because this always, all of our issues go down to the patient safety issues. In short, just to give you an idea how well it's worked, you can see some of our basic as well as advanced healthcare simulations. And I would suggest to you that this at least shows that, granted, not great information, but it does show that they were effective in demonstrating the concept. And I would submit to you if they demonstrate the concepts to the individuals, that hopefully those concepts are perhaps learned in a better manner than they would be if it were simply a matter of standing there talking. Now, the second part of why you use simulation is, okay, this works as far as the teaching and the education, the training while you're here, or at your own institution. But are there ways we can use this to not only teach and educate, but can we use this to find out if it works? I mean, let's face it. Right now, what we do to find out if it works isn't that great, right? Our traditional methods, simply we kind of go around, we walk around and ask, well, how did it work? Did you do okay? Are you doing the things you're supposed to be doing? Get your surveys. The surveys are fine, but let's face it. It's certainly recall bias. Yeah, we're doing a good job of this. It always seems to happen if you use those surveys. It's kind of fascinating. If you look at it, your local group, your small team, always is doing great. When that team has to interact with another one, that's where all of the problems are, because usually that's someone else that's having the problem, right? And unfortunately, it's been pretty well established that doesn't really necessarily have a good correlation with the actual performance itself. You know, unfortunately, in this situation when we're evaluating, you know, we tend to be where we're usually always in the past, we're always trained in isolation, and we tend to be evaluated in isolation as well. And when you actually put a simulation back into the process, perhaps we maybe can get away from being evaluated in isolation, but in fact being evaluated like it really happened. You know, so how can we develop competency? Well, you know, we have the standardized methods that we talked about before. But if you think about it in a simulated environment, you can use a checklist for those skills and objectives. That you can have individuals that are content experts already decide, what are the objectives and the skills of what we're trying to accomplish here? What are we trying to see that we've succeeded in doing, working as a team as well? Additionally, you can have a true independent observer. And in a simulated environment, you can reproduce it over and over again. So it's not a matter of just if someone happened to wash their hands one time, but set it up in a situation to where you can identify reproducibility, and this really can determine whether there's a competency there or not. And lastly, I think in this respect, the healthcare team really does test together. This is how we do it. It's fascinating. Most of the time when we actually test or check out competencies, we're taking some little test somewhere, that you've read it online, whatever it may be, and unfortunately what happens, it's in an individual setting. We never put the patient in the process. Whereas in a simulated environment, we can put the patient, simulated perhaps, put the patient in the whole process with all of us there, and really perhaps can identify how we really do function. This gives you some idea of what we do here, and it is basically a checklist if you look at it, but it deals with the things you learn in a TeamSTEPPS approach. You have the situational awareness in this particular situation, where the vital signs asked for. Now, this is for a medical student going through this, medical student and nursing students going through a simulated environment for a checkoff for competency. Teamwork skills, was there a structured communication tool used? Was that closed-loop communication used? All of these things can be shown, and it's basically yes, no. Now, you can certainly put the feedback comments on the side, but if you're really focusing on a true summative assessment of an individual, the yes, no, these things were done, and you set your goals. If your goals are all of these things should be accomplished, then 100% should be accomplished, then that's where your goal is. Really, if you think about simulation, here's what it does for us when you look at Miller's Pyramid. It really goes from what we do today, which unfortunately are really that you know how. And I would suggest to you that if we gave you a test on any of the skills of TeamSTEPPS, it's hard to write a test that most of us don't already know. Let's face it, most of this is common sense. Doesn't mean that we do it, but unfortunately, you can get it right on a test. And so you may even try and make it a little more challenging as far as the test is concerned and perhaps get some of the approach to where you can move to that knows how. But I think the real concept here with simulation is we go all the way down from this knows, which I don't think is certainly not the ultimate goal for any of us. But we really can, at the very least, get to the shows how. But I would submit the does probably is where most of the simulation really is. So in conclusion, I think simulation enhances TeamSTEPPS in many different ways, whether that be the master training, the training you'll do in your own institution, whatever it may be. But it helps by improving that learning. It really moves from the didactic lecture where you remember one thing, and hopefully you remember one thing or these two things today from this lecture, moves from that didactic lecture through true active learning. And then lastly, as far as your assessment of your implementation, we really can identify where you're going from that knows all the way through that does, and to really make an effective difference. And from that, hopefully improve patient safety in your institution. And with that, I'll turn it back over to Chris.
Thanks, Jim. Thank you very much. I appreciate it. That was a great presentation. We've had a lot of questions coming in the discussion area and a lot of good conversation. So one of the things that people were really interested in was the idea of whether or not you think that training should be in a multidisciplinary approach, or if it should just be people separated out from other disciplines.
Yeah, that's an easy one for me, I think. Unfortunately, we have trained typically in our isolated worlds throughout the history, really, of the way we've been training in medicine. And unfortunately, the first time we ever actually work together is when the patient's involved, or the patient, I would say, is at risk. And that's an unfortunate situation. So I absolutely believe this needs to be multidisciplinary. You know, one of the ways I explain this, it'd be kind of like, understand I'm a Saints fan, so it'd be like Drew Brees goes out there and he's throwing 10 yards down the field, a little to the right, over and over and over again. He's hitting his target perfectly. Well, somewhere on the other end of the world, you have the receivers that are running down 10 yards and running over. Well, unfortunately, some of them run a little faster, some of them run a little slower. Well, if the only time you ever put those two together were on the field when they're playing a game, I would suggest they wouldn't succeed very well. And unfortunately, that's what we do every day. So absolutely, I think it's key to have an interdisciplinary approach to training.
So I think that this leads into a follow-up question. What would happen, you know, definitely in the hospital setting, teams are constantly shifting and they're definitely going to be different in composition as to who shows up, you know, to a code compared to who was together in the simulation center. So does this learning carry over to the fact that the teams are always made up of a different composition of professions?
Well, I mean, I think that's one of the great things about the TeamSTEPPS. You know, you can, and you know, there are all sorts of other proprietary type concepts out there. But in short, if everyone is trained in, you know, I don't want to, I'm not trying to make it sound minimalist, but if everybody's trained in the same language, okay, and meaning the TeamSTEPPS language, that as long as everyone's on the same page, then yes, communication can occur. I mean, just case right now is like, as long as everybody can speak English, then we can communicate together, and we can get the job done. So I do think that it's important that not just a select few need to be trained, but in fact, truly, you do need to bring it through your entire hospital system to make a difference. Because you're absolutely right. What will happen is you'll have one person that's trained in it, but no one else is, and then you won't succeed. And that really is important, where it has to go through the whole hospital.
Can you talk a bit, I know this just from, I think, experience with you guys, in the way that you have done training at Tulane in the system, the idea has been to kind of do, I think you guys call it a dosing approach, where you might tackle a problem at a time or teach individuals a certain group of tools in a certain setting at a time, and that's how you thought about rolling it out through more and more parts of your system?
Well, right, that's really what, you know, it's almost impossible to think about it in larger institutions just to have everybody show up. Now, a wonderful goal, and I know there's some hospitals that have successfully done that, and now simply it's a matter of everybody that comes through gets trained. Once they are hired, they go through a TeamSTEPPS training. And then, you know, that's the ultimate ideal situation. I have no doubt about that. But it is a challenge. And how we've done it, it really is the idea of taking, if there's a problem that occurs, then we identify that particular area. Is that OB? Is that ER? Is it the SICU? And we've actually trained TeamSTEPPS in groups in those settings. In other words, SICU as a unit, but that includes everybody in there. It's still a multidisciplinary approach, but it's focusing on one particular area as opposed to saying, okay, you know, 75 people come over today, another 75 come over next week, and continue to roll it out from that standpoint. The nice thing about that is that kind of the idea of the why change is necessary is that, you know, there is that need for change that is seen because they identified that something went not necessarily wrong, but something could have been done better, and that helps them when they come through the whole process.
When you were talking about how what you've been doing with the rural hospitals, this is something where you've been going out to them, or have they been coming into you at the center?
No, it was actually set up by the, and I apologize, our administrative director will probably be able to tell you exactly what governmental agency covered it. But the Louisiana Hospital Association has actually rolled this out and sponsoring them to come to us. For the initial TeamSTEPPS training. The follow-up, that is, the immersive aspect of it, when they come back, those are, we initially set it up as a pilot, and then we've had those hospitals then come to us since that time. Now, we can modify it according to what they want at each time. In other words, there may be a hospital that has OB available all the time. They don't need to go through OB scenarios in the emergency department, for example.
Right.
So those are areas that we do, we still can tailor it according to what they want. But again, the main focus when you want to come back is really reinforcing the teamwork approach to whatever that problem is.
How do you think this kind of shifts gears a little bit away from the macro system-wide training level down to, actual utilization of some of the tools? So can you speak a bit on how you think TeamSTEPPS is or is not useful in forming a shared mental model around terminology and how sometimes different professions or different departments have maybe different terminology for things?
Right. Well, I think, honestly, that's where I think TeamSTEPPS probably does us the best service of all. It's the concept that we are talking about, the shared mental model, that particularly the terminology, the language is the same. So if someone says they're concerned, for example, then, all of a sudden you start thinking about that. Or if you go all the way up through the concept of this, this is a safety issue. If everybody's gone through this, all of a sudden they start hearing these words, you would certainly hope that start giving those individuals pause of what they're doing to reassess. So I really think that is the main focus of the TeamSTEPPS program in itself, is it really does put a true common language out there and understanding of what really needs to be done as well. I mean, again, we all want to be safe with the patients. I say this all the time. Nobody's walking into a hospital today to try and hurt somebody. But it's going to happen. But it will happen, no matter what we're trying to accomplish. So the whole goal of focusing as a team, we go back to the airline industry concept. Everybody that's dealing with an airplane can stop that plane from taking off. I thought it was fascinating that I had a resident that actually didn't make it back in time because he was from vacation. But what happened was this, is that he was on a plane that had a part changed. Well, that person had forgotten to just sign a piece of paper on a very straightforward part and had gone home for the day. Unfortunately, this was in Dallas, so the guy lived a long way away from the airport, and took him an hour and a half to even get back because he had to come back to confirm, even though they had somebody else that could have actually looked at it. But that's the whole team approach. It's because of that one person was basically the holdup of letting that plane leave. So it's a common mental model there, because then it's a common language as well. And that's one of the areas we need to continue to strive and move toward in medicine.
That's very, very, that's very good. I was wanted to shift a little bit again. We've been receiving some questions about how you actually do some of your work at the simulation center, and there were some questions around whether or not you use standardized patients ever, or is it all through the use of the mannequins and such?
It depends. Use both, really, is what we'll do. It again depends on what our goals and objectives are at each particular situation. We try and utilize the simulators as much as possible, just from the ease of use and timing and things of that sort. But without question, it does occasionally require a standardized patient in the situation. I'm thinking with respect to the ones we do for the master training we do here, most all of those really are simulators. But if you think about it, when we throw in the resident, while that's not really a standardized patient, it is a confederate within the system. Mm-hmm. And in a good way, that really is an equivalent of a standardized patient, in that person's playing a role within the whole simulation itself. So we do both.
That's interesting. I somebody just wrote in, I think it might be a good question for you. How are you measuring impact of your simulation training? Now, I realize that through the national implementation, that's not something that we're working on right now, but some of the other trainings, the work you're doing with the rural hospitals through LHA, or perhaps some of your internal work that you've done with Tulane, how do you go about measuring impact?
Well, with the rural, that's been a challenge for us, I'll admit. We've tried to figure out how we can really identify that in a meaningful way, short of, the concepts of the teamwork surveys before and after training and the like that we could certainly try and do. And we'll struggle with that a bit, and I would suggest to you that, in fact, if we can figure that out in a good, meaningful way, then I think we have a great opportunity for a real large grant from that side of things. But unfortunately, right now, you're right. We really don't have that, and because of that, it's a matter of it comes down to it really is sort of the nose or the feeling of the individuals as far as our impact. And with respect to in the hospital itself here, some of the few things we've done is that when, for example, when we do training, when they were identified, one of the units, for example, had a higher than expected central line infection rate. We had all of them go through team training with placing central lines. Now, their infection rate did go down. There's no way I can sit here and point to the fact that it had to do with the simulation. I'd love to say it was, but that wasn't the only thing by any means that was done in that particular setting. Let's face it, when you're being watched closely, the Hawthorne effect alone is probably good enough, at least to some respect, to get it to make a difference. So I'm certainly aware of that, and that's the big challenge. Is really the outcome side of assessment. That's the holy grail, and I'd love for somebody to tell me how to do it in a more meaningful way, and I'd be happy to start tomorrow.
Yeah, I agree. It's a similar problem that I know a lot of people struggle with. Using the patient safety, the culture of patient safety surveys like the HSOPs.
Right.
You mentioned the teamwork surveys, like the attitudes and perceptions questionnaires. Those are on the AHRQ website, but those are definitely. It's not as fulfilling as you may like it to be with this. So.
Yeah, I'd love to figure it out, and I tell you, if somebody figures it out, then we're doing great. But that's going to be so much smarter than me.
Yeah. There have been a couple questions coming in that I want to answer really quickly, just about the whole way that this program works. Tulane is part of a network of what we call their regional training centers, and they're all funded by the Agency for Healthcare Research and Quality. We're talking about there are 5 centers nationally: University of Washington in Seattle, University of Minnesota in the Twin Cities, Tulane in New Orleans, Duke University in Raleigh, and the North Shore Long Island Jewish Health System, which is in Long Island. And all of these centers provide trainings funded by AHRQ during the course of the year. So these are free trainings to anybody who wants to attend. You have to pay, of course, to travel there. So if you're flying there, you have to pay for your flight and hotel and your food, your dinners and such. But other than that, everything is free. You receive free materials when you come, and this includes all the TeamSTEPPS tools and as well as information, very, very in-depth information, how to teach them, facilitator notes for each slide in the presentation, as well as a lot of background information and other exercises. This all comes in a giant binder you receive when you come. You receive also a DVD, CD with all of the material on it and a couple other things. That's all free to you as well. When you finish your training, you're enrolled in an online discussion forum just for your classmates that came to that training, so that you have an opportunity to get back with them afterwards and ask each other questions. So this is all free. As you can imagine, because it's all free, and because I think it's a very good program, others do too. It really, really fills up fast. So right now we have some waiting lists going on for our trainings that go throughout the course of the year. We work, to be transparent, we work on a federal fiscal year cycle, so sometime in September when we get refunded, that's when we can start work on coming up with new trainings. So my advice to all of you out there who are very, 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 very interested in coming to a training and being a part of this, go on to the TeamSTEPPSportal.org and you'll link over to our registration site, sign up for one of the trainings on the wait list, because what will happen then is you'll get first dibs when the new trainings come out. So that's how this program all works. So I just wanted to drop that in here and let you all know about that. Other than that, Jim, I want to thank you very much for answering all these questions. There are some other questions that have come in, and I think if it's okay with you, we'll send them your way and see if we can get some answers, and then we'll post them on the TeamSTEPPS portal.
That'll be fine, sure. Be happy to.
That's great. That's great. We've got some upcoming webinars. August 14th and September 11th are the next two webinars, and so head on over to the portal, and as our topics and speakers are announced, they'll be up there, and you can see what's going on. I know that an upcoming webinar will be talking about system-wide implementation, especially at the North Shore Long Island Jewish Health System. And if any of you had a chance to attend the national conference, which took place last month in Dallas, you had a chance to see them speak, and a lot of people got a lot out of it. We're very excited, wanting to connect with them, so we're bringing them back to go to a larger audience. So other than that, right up there is our email address. Drop us an email if you have any questions, if there's anything you need from us. But with that, I'd like to thank you all for taking an hour out of your day today and joining us. I'd specifically like to thank you, Dr. Korndorffer, for coming in and spending this time with us. I think people really enjoyed it. I really enjoyed it. There'll be a recording of it posted on the TeamSTEPPS portal next week in case anybody joined late or wants to share it with a colleague that maybe couldn't come today. So thank you all very much again, and thank you, Dr. Korndorffer.
Great.
Thank you very much, ladies and gentlemen. At this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.